We're going to do a transurethral needle ablation procedure. And before that, after doing the urethral xylocaine jelly and xylocaine solution in the bladder and waiting for half an hour, giving him oral Demerol and Ativan, I do a prostate block. And this is what I'm going to demonstrate, a prostate block. And that is very, very important and paramount in getting a good results. First, I reconfirm the transverse diameter of the prostate, which I had done before also, but this to reconfirm transverse diameter. The transverse diameter is about 36, 38, and so that's perfectly fine. And then I do this is the bladder. If you can notice, this is the bladder, this is the seminal vesicle, this is the prostate. And what I call this, the Mount Everest sign. This is where all the neurovascular bundles are, Mount Everest sign. So that's where I'm going to inject 10 cc's of 1% xylocaine solution. Why 1%? Because I notice 2% sometimes gives you hypoglossal. So this is the area where I inject. If you notice, the black thing is, and then I let a little local run down between the prostate and the bladder and the rectum, I mean. So if you notice, I am just at that spot only, 10 cc's on each side. So this is one side. Then I go to the other side again. There's the Mount Everest sign. You can see that. That's what I call Mount Everest sign. And I put another 10 cc's over there to make sure that I get a block on that side too. Notice the block again. It gets dark, means fluid going in, and I let some slide down between the rectum and the prostate, and go back and make sure that all the neurovascular bundles are done. So that's basically it. And we tell the patient to turn over. The transurethral needle ablation thing comes in a pre-packaged, as you know, and it's completely sterile, and we just take it out of the pre-package and put it on the sterile table. Disposable cartridge which comes completely out of the package, and this is the telescope, which is a very thin telescope which we slide in. Once you slide the telescope in, make sure that it's dry, and I've got a grip on it because this is very tough. And then once I slide it in, I clip this. This goes to the transducer, and this one goes to the water. If you notice, goes to the water. Okay, go in. If you notice, give me a little squirt to get rid of the air bubble. Good. So we are actually going into the bladder, okay? So now we are going into the bladder. I want you to take a big breath in and out. There you go. Beautiful. All right, I'm just now in the bladder. Now relax. Take it easy. Don't do anything else. So I'm going 14 at the, because the width is 41, it's 14, 16. I go 14 at the bladder base, 1 centimeter distal to the bladder base, okay? So shut the water off now, and then we put it right here, 1 centimeter distal to the bladder base. If you notice, it goes in, and the treatment is started, and beautiful treatment, beautiful.
Much better picture on this one.
See what a beautiful parallel treatment. So the patient, the needle is in the right depth and right position. There you go. One treatment is over. I go back there. Now what I do is I just go back to the other side. Again, the same treatment right here, and I go 1 centimeter distal, and the needle is curved a little bit, so I go curved, and then that's it. Start the new lesion. So each lesion is about, I treat at 3 o'clock and 9 o'clock position. It might be a little bleeding from the mucosa, which usually stops with the treatment. You may need 3 rows, which means base, distal to the base, mid gland and apex. And you may need 2 mid glands depending on how long it is, and 1 at the bladder neck. So that's his treatment protocol. Again, look at the patient, he's just lying there, absolutely relaxed. Good prostate block always helps. All right, so we're done with this treatment. If you notice, I'm going to go to 16 now and go 1 centimeter distal to where I was. I was right here. Go 1 centimeter distal and tried the treatment right there. So beautiful view. There's no problem with the view. And once I do this row, then I go 1 centimeter proximal to viro montanum and do that at 12. And then I decide whether there's enough prostate tissue in between the row, the mid-gland row, and the proximal to the viro montanum row to see if I need one more treatment at that place. And we know these patients have significant symptoms of prostatism. They have failed alpha blockers and they opted to undergo an in-office procedure. I decide on tuna, which is Prostiva, or microwave, which is cool thermotherapy, based on various factors: size and shape of the gland, the patient's comfort, and patient's own wishes, after they read literature on both. This patient's gland is relatively on the smaller side, and he opted to undergo a tuna procedure. Similarly, now all I do is I just turn this around and do this, but just to make sure that I'm not too distal, I just have one quick look there. So here it is again, and I put a little tug or little pull on the cartridge. So when you put a pull, because the needles are curved, it goes in more snugly inside. Then stop now. Okay, median lobe. I wanted to take this, okay? Right, there's a median lobe at 12, okay?
Yeah, his volume was 37.
Yeah. So it was a banana gland.
Okay.
So I just did 3 roll. We don't need it. We didn't need to do 4. We only did 3. So how are you doing?
Pretty good. This feels like I need to pee about it.
Yeah, that's because we are filling your bladder up. In just a moment, we're going to take your this is the last treatment. We're going to take the cartridge out and have you go to the bathroom and go and urinate. And we will give you a red rubber catheter to take home with you, just in case you have any problems. Urinating. You can self-cath yourself. Okay.
Okay.
Otherwise, the chances of that you needing a self-cath is, I think, 20% or so, and you will have some difficulty in urinating initially, but it should get better. 9 seconds, that's fine. All right, there you go. We're done, and we're retracting. We're just taking the cartridge out, and you're all set. Great. Fantastic.